Okay, class. This is the last chapter in Module 6, and it is Chapter 26, and it is in regard to drugs used to treat thrombolytic disorders. So, let's get started. So, slide 2, objectives. The objectives of this lesson is to explain the primary purposes of anticoagulant therapy, describe conditions that place an individual at risk for developing blood clots, and nursing interventions used to prevent these conditions, to identify the actions of platelet inhibitors, anticoagulants, thrombin inhibitors, glycoprotein, LLB and LLLA inhibitors, and fibrogenic agents. Slide 3, objectives continuing, is to describe specific monitoring procedures and laboratory data used to detect hemorrhage in the patient taking anticoagulants. And last but not least, to describe the nursing assessments needed to monitor therapeutic response and adverse effects from anticoagulant therapy. So I am moving to slide number 4. We're going to talk about thromboembolic diseases. So thromboembolic diseases includes the process of forming a blood clot or thrombus. Fragments of a thrombus can break off and circulate until it's trapped in a capillary, creating what they call an embolus. Clotting cascade is activated when a blood vessel is injured or with increased viscosity. That's the thickness of the blood. Intrinsic clotting pathway and extrinsic clotting pathway. So intrinsic clotting pathway is activated when there is damage to a blood vessel. Extrinsic clotting pathway is activated when there is damage outside of the blood vessel, usually to the tissues. Please refer to figure 26.1. But whenever you see N is within, and whenever you see X, it means out, okay? So I did include a picture so you can kind of see. Oh, sorry, that's slide number 5. Sorry, I'm trying to pull it up here. So I just mentioned, okay, so you have the blood starting to form a clot. So what happens with a normal vein, the blood flows one way. So when you have a damaged vein, the blood if the flaps are damaged, the blood can flow up and down, okay? Flowing in both directions, and the blood starts to accumulate in the vein, so you can see that on the sides of the vein. That's a thrombus. So when the blood moves slowly, a clot of a thrombus can form. A part of the clot can break off and travel into the bloodstream. That's the embolus. So your thrombus is that the clot is forming. When a part of that clot breaks off and travels, that's the embolus, okay? So slide number 6. So non-pharmacologic treatment of thromboembolic diseases. So prevention of conditions that causes clot to form. So these things cause clots to form. Okay, that's what that's saying. Immobilization with venous stasis. So immobility when there's blood is pooling in a vein, okay? Surgery trauma to a lower limb can cause a clot. Heart failure and vasospasms can cause a clot. Cancers of the lung, prostate, stomach, pancreas, pregnancy, and oral contraceptives can contribute to clot formation. Ways to prevent stasis, leg exercises. So really venous stasis is because the blood is pooling and the person is just being stagnant, not doing anything. So ways to prevent that is to get people to do leg exercises, move their feet up and down, do marching motions with their legs, things like that. Just some kind of exercising, get up and walking. They can wear stockings. I was going to say compression, but that one is coming. Leg elevation and sequential compression devices, which is typically you may hear compression, stockings, socks, tights, but some kind of compression device. Revascularization treatments, meaning we want to get the blood flowing again, right? Percutaneous coronary intervention and coronary artery bypass graft. So with this particular disease process, prevention is the best treatment. Patients need early, regular ambulation after surgery. Develop the following a turning schedule for patients on bed rest. So we got to keep that patient in motion, because if they have surgery and they're just laying, so now blood is wanting to pool. If it starts to get thick, like if you back up to slide 5, the blood starts to slow down and do things, and it starts to form a clot. Part of that clot breaks off, and then it becomes an emboli. And it can travel anywhere. It can travel to the lungs. It can travel, and block another artery. So that's kind of how that connection works, okay? So slide number 7. Drug therapy goals. The primary purpose is to prevent platelet aggregation. Aggregation means they're coming together and they're clumping together. So we want to prevent that, because when they start aggregating and clumping together, that's when the clot starts to form, and the possibility of part of that clot can fall off and travel, okay? Or inhibit steps in the clotting cascade. 4 types of agents are platelet inhibitors, anticoagulants, glycoprotein inhibitors, and thrombolytics. Anticoagulation therapy prevents new clots formation or extension of existing clots. So anticoagulants do not dissolve clots. Only thrombolytics do this. So take note. Anticoagulants do not dissolve the clot. The thrombolytic medications do that. Platelet inhibitors prevent platelet aggregation, meaning clumping and gathering together, and can prevent stroke and heart attack. Okay, slide number 8 is a question. And then I'm going to move on to slide number 9. So, laboratory tests that you are going to see in regard to the thromboembolic diseases. The coagulant test that you're going to see, is going to be PT, or they call it prothrombin time, and it monitors warfarin therapy. You may see an APTT, and that's activated partial thromboplasmin time. That monitors heparin therapy. INR is an international normalized ratio. It monitors warfarin therapy as well. You might see platelet counts on lab work. Diagnostic tests, PT, APTT, hematocrit, platelet count, You might Doppler studies, exercise testing, serum triglycerides. We're back on that cholesterol again. Arteriogram, cardiac enzyme studies. So PT evaluates the adequacy of the extrinsic system. APTT evaluates the intrinsic coagulation system. PT and INR determine the adequacy of warfarin doses. So often you're going to see a PT and INR together. Those two pretty much kind of go hand in hand. You will see those labs together. Let's see. So slide number 10, chapter 26. They're talking about nursing implications. So let's get back to that nursing assessment. You got to get that patient's history. Are they having any current symptoms? You need them with medications, both prescription and non-prescription. And a basic assessment, you want to obtain their vital signs and check their breath sounds. You want to check their mental status. You want to assess for specific signs of reduced tissue perfusion. So you want to check their skin. Is it looking blue, purple? You know, is it like Raynaud's where all the color go away and there's no blood flowing to the fingertips or the toes? So make sure you're assessing for tissue perfusion. Collect data about any pain that they are experiencing and verify their state of hydration. Are they dehydrated? Are they getting enough fluids? You want to monitor those vital signs and mental health status every 4 to 8 hours or more frequently, depending on the patient's status. Okay? And then we're going to move to slide 11. So now this is talking about patient education. So patient education is huge, especially if this is a new diagnosis to a patient and they are probably still trying to process the information they were told. You know, some people might be in denial, and so it's important to stress, to educate patients on the disease process, on the medications they're taking. What signs and symptoms to look for, and things like that. So here we are, patient education. Diet and nutrition. And I'm sorry I said no. I thought I lost my video because if I stop, I can't pause and continue, y'all. So I would have had to have started over. But okay, let's assess and talk about their diet and nutrition. Limit intake of leafy green vegetables. I'll tell you the rationale behind that in just a second. They want to limit their intake of leafy green vegetables. They need to drink 6 to 8 ounces glasses of fluid every day. Exercise and activity after surgery to prevent venous stasis. Do not flex the knees or place pressure underneath the knees. Avoid being motionless. Medication regime, they need to wear medical alert bracelet. Dose and timing, common and serious adverse effects, you need to educate on those, and drug interactions. Report all signs of bleeding. You need to educate the patient to report all signs of bleeding because you have to remember these are anticoagulant medications. So they're breaking up clots. It's thinning out the blood. So they have a tendency, if they bump their elbow, they're going to bruise. They may bruise. They may get a cut, and it may bleed longer. Then that's what the purpose of a PT and INR is, because it tells us if they're clotting in the time frame that they're supposed to be clotting. Okay, some of that, more of that will come together later, but I just wanted to kind of make that connection. High intake of leafy, so I said back before, limit intake of leafy green vegetables. So high intake of leafy green vegetables may interfere with the effectiveness of anticoagulants. They contain vitamin K, which is used as an antidote for high doses of warfarin. So what that means is if they're eating a lot of green leafies, and they're high in vitamin K. Vitamin K is used as an antidote for warfarin. Well, warfarin is used to thin the blood. So then, if it's an antidote for that, it's going to interfere with that process. Okay, so here, let's start with the drug classes. We got platelet inhibitors. This is slide number 12. Aspirin is probably one of the most common ones you will hear over the counter. It's an NSAID, so a non-steroidal anti-inflammatory. It platelet aggravation inhibition. So what that means is it helps keep the blood cells from clumping up and aggregating together, okay? In men, it reduces the risk of myocardial infarction. In women, it reduces the risk of stroke. Used in men and women with acute MI. So they may say you need to take an aspirin a day. So your NSAID, your non-steroidal anti-inflammatory drugs, are a class of drugs that can reduce pain, inflammation, and fever. And you all probably know that one because y'all probably come across that one. Everybody kind of seemed to know the NSAID. So moving on to slide 13. We are still talking about platelet inhibitors. So the action is to inhibit the blood from clotting altogether to begin with. Is used primarily to prevent MIs and stroke, prevent blood clots from forming. Common adverse effects: abdominal distress and hypotension. So I would educate patients that take this with, make sure you have something on your tummy. Serious adverse effects is neutropenia, granulocytosis, and bleeding. And with clopidogrel, thrombotic, thrombocytopenic purpura, TTP. So again, the meds in this class, you are going to probably see aspirin. Plavix is another common one. Okay, we are on slide 14. So now we're going to talk about FACS-XA inhibitors. So these particular medications reduce the risk of stroke and systemic embolism in patients with non-vascular atrial fibrillation. But Trexaban prevents, and this is a prophylactic, so prophylactic means to help prevent, prevents DVT, deep vein thrombosis, and pulmonary embolism, is PE, in adult patients hospitalized for an acute medical illness or at risk for anyone at risk for thromboembolic complications. Common adverse effect is bleeding. You have to remember, bleeding is going to be big in this category because you're trying to keep the blood cells from clumping together. So if you're thinning them out, if you have a cut, that means you're going to bleed more because the medicine is doing what it's supposed to do. So FXA inhibitors do not need to be monitored with anticoagulant tests. Factor XA inhibitors do not need to be monitored with anticoagulant tests like that PTINR and the APTT. Primary therapeutic outcomes expected from the XA inhibitors are prevention of deep vein thrombosis and pulmonary embolism, and reduce the risk of thromboembolism in patients with atrial fibrillation. So to elaborate on this a little bit more, please refer to table 26.1. Okay, we're moving on to slide number 15. So this drug class is anticoagulants. So low molecular weight heparin is in this category, and you probably will see that one quite a bit in your nursing career. It's used to prevent deep vein thrombosis after hip replacement or abdominal surgery, prevent MIs, myocardial infarctions, combined with aspirin. Common adverse effects is hematoma formation. That's big, like patches of blood, because you have to remember these medications are thinning the blood, so bruising is easier, bleeding can be longer, so they got to be real mindful. Okay, and bleeding at the injection site. So common adverse effects is hematoma formation, bleeding at the injection site. Serious adverse effects is bleeding and thrombocytopenia. Okay. A common one you may see in this category is Levinox. These are administered subcutaneously only. Fondaparinux is a sensitive factor XA inhibitor, not a low molecular weight heparin. So, slide number 16, speaking of Levinox. So, this is a sub-Q. Levinox is a sub-Q injection into the anterolateral or posterolateral abdominal wall every 12 to 24 hours. Don't expel the air bubble in the pre-filled syringe prior to injection. That needs to stay there. When you're ready, that's when you'll push that air out. Inject the entire needle into the skin fold, and you want to inject slowly, leaving needle in the place for 10 seconds after injection. Do not rub the injection site. And if patient is getting these for a certain amount of days, it is imperative, even if they get in more than one of those, you need to rotate or alternate your injection sites. Okay? Okay, slide number 17, we still talking about anticoagulants. Heparin. The action of heparin is it's an antithrombin that neutralizes thrombin in plasma. It's used to treat deep vein thrombosis, pulmonary embolism, and cerebral embolism. So cerebral, brain. So it's used to treat those. So pulmonary, lungs, deep vein, legs, cerebral, brain. Can be given subcutaneously. It can be given IV push, and it can be given in an IV infusion. Okay? Doses vary depending on the route. And this one you have to monitor APTT, platelets, and hematocrit. Okay? So common adverse effects, again, is that hematoma formation and bleeding at the injection site. Serious adverse effects is bleeding and thrombocytopenia. The antidote for heparin is protamine sulfate. So antidote means to reverse the effects of the drug heparin. The reversal drug is protamine sulfate. Protamine sulfate, if somebody got too much heparin and they need to reverse that process, they will get protamine sulfate. Put a star next to that one. Okay, moving on to slide number 18. So heparin administration. Be sure to confirm the calculation with another nurse. Be sure to confirm the calculation of heparin with another nurse. Be certain the dose strength is correct, meaning the dose that is ordered is the actual dose that is being administered, because don't forget, this can be given multiple ways. It can be given sub-Q in the tummy, it can be given IV push, and it can be given an IV therapy. So please be certain the dose strength is correct. Therapeutic range for APTT is 1.5 to 2.5 times the control. Subcutaneous injections into the abdomen, don't massage that site. You want to just give it and hold it there for 10 seconds, and then that's it. You want to alternate your sites. Use a 90-degree angle and apply gentle pressure after. Please refer to figure 26.2. And so just again, the APTT, the activated partial thromboplasmin time, is a blood test that measures how long it takes for the blood to clot. Okay? And when patients are on those kind of meds, we need to keep them in what they call a therapeutic range, because if they fall outside of the range, especially with warfarin, you'll see them some meds, they'll adjust the dosages. They may tell them to drop down 2.5 milligrams, or they fell out of range, you need to bump it up 2.5 milligrams. And so you might see some variance with that, but it is very important to know that those tests are crucial, because it do tell us if they're staying in a normal clotting time range. Okay, chapter 19. And so I put a picture up of what a thrombocytopenia looks like. That's what it looks like. And that's almost like that hematoma thing too. Like the blood is pooling in an area. That's why I was trying to make it seem like a space. So common adverse effects is bleeding or hematoma at the injection site. Serious adverse effects is bleeding. It could be bleeding in the mucosa membranes, the skin. It could be in the urine, the stools. It can cause thrombocytopenia, which you see in the picture. I put an arrow there. Or it can even be internal bleeding. So those lab works that we look at is crucial to know where that patient is in that blood clotting process. Okay, slide number 20. We're still talking about anticoagulants. Okay, so Coumadin, warfarin. It inhibits the activity of vitamin K, which activates certain clotting factors. It's used in treatment or prophylaxis of a deep vein thrombosis, embolization from atrial fibrillation or heart valve replacement, or pulmonary embolism. Emboli, broke off and went up and got lodged in the lung, pulmonary embolism. So you want to see, these are the values you want to see. The target, INR of 2 to 3 patients with atrial fibrillation, stroke, and DVT. We still talking about, and deep vein thrombosis, INR of 2.5 to 3.5 for patients with mechanical heart valve device. So these are kind of some of the ranges you want to see these numbers. And again, the INR is a blood test that measures how long it takes for your blood to clot. So, slide 21, let's talk about Coumadin. So we're still talking about Coumadin. So the adverse effects is bleeding. Again, could be in the mucous membranes, internal bleeding. It can show up in the stools or the urine. So naturally the urine might look bloody. Stools may look darker or tarrier because blood will make the stools look dark. Surgical dressings and drains. You need to be mindful of watching those, how much blood is coming, if any blood or a lot of blood is coming out of those. This medication is contraindicated in pregnancy, not to be given to a pregnant mom, okay? The antidote is, first of all, stop using it, and vitamin K. No any drug interactions that may pertain to Coumadin, okay? Slide number 22. We are talking about Coumadin pre-medication assessment. Pre-medication assessment means you're assessing them prior to medicating them. So, before you give them that next dose of Coumadin, you're doing a pre-medication assessment. Before you give them that medication, you want to check their most recent PT-INR. You want to make sure that that's in range because the dosage that they get is going to be determined what their PT-INR is. You want to assess for any bleeding. Again, them purple spots or bleeding into an injection site. Checking their extremities. Provide dietary education on foods high in vitamin K. Green leafy vegetables. Note a variety of dosages is available. So that's what I was talking about. When I said 2.5, that's 2.5. So Coumadin comes in 1, 2, 2.5, 3, 4, 5, 6, 7.5, and 10. So if a doctor wants a patient to have 8, they'll probably be taking a 6 and a 2. And depending what their labs is, they'll be like, no, give them 6 to tell them to do 6 this time. Because the dosaging of this medication is based on the lab value of the PT and INR every time. So they might be taking Coumadin for 2 or 3 days and then they're due for a lab draw. So how they continue is based on those PT and INR readings, if that helps connect that a little better, okay? Stress need to comply with regime and need for laboratory data. That's what I'm saying. It is critical that they get their lab values when they are supposed to be drawn because the dosages they take of Coumadin is based on those lab values. Okay? Slide number 23. So, correct dosing. Key in the treatment of conditions used to control the clots. Use medication administration record for scheduling. Make one-time dosages clearly. So if this is a one-time dosage, that needs to be clearly documented, okay? Never administer an anticoagulant before first checking the chart for most recent laboratory results. That is going to be key. Start this section, ladies. This is huge. You always, with anticoagulants, if they are getting that and doctor have labs ordered on a routine basis on a consistent schedule, those labs have to be done prior to giving the medications because, again, it may be the milligrams or the amount they get is adjusted based on those lab values. So my note says anticoagulants must be administered on schedule exactly as directed and not in larger, more frequent doses for longer than the prescribed time. Taking too much medication can cause severe bleeding. So that's why looking at those labs is critical. So whenever you're dealing with Coumadin, look for those lab values, okay? Let's see, 24 is a question, 25 is a question, slide 26. Okay, so here we got thrombin inhibitors. Pradaxa, it might be the most common one you see. Action is a direct thrombin inhibitor. Prevents conversion of fibrinogen to fibrin, which contributes to clots. It reduces the risk of stroke with non-valvular atrial fibrillation. Pre-medication assessment. Okay, this is the stuff you're going to do before you get the medication. Anytime you see pre-medication assessment, it's the assessment you need to do before you actually give the patient that medication. So you want to check for any bleeding. Back to checking the extremities, checking injection sites. You want to monitor those labs. And pregnancy. If someone is pregnant, and some of these are off limits in pregnancy, but if you are dealing with a pregnant patient, know what the protocols are for that patient. Okay, slide number 27. I'm gonna try to attempt to call this medication out the Bigatran. So it's a safety alert with this one. Capsules must be swallowed whole and are sensitive to moisture. So somebody can't have them in their pocket and next to the body and they sweating because they're sensitive to moisture. Bottle must be used within 30 days. And the adverse effect, again, as with most of these anticoagulants, is bleeding. Okay, slide 28. It's talking about glycoprotein inhibitors. These meds block receptors on platelets, preventing aggregation and clot formation. So, if it's blocking the receptors that causes the platelets to clump, then they can't aggravate. That's what that's saying, aggregate. It's used to prevent clots from forming from the debris often released during percutaneous coronary intervention procedures. So basically, it's preventing the clots from forming because of like little, let's call them little emboli that's floating out into the bloodstream. Okay, so they're preventing the clots forming from the debris associated with this procedure. Serious adverse effects, again, is bleeding and that thrombocytopenia. Laboratory values to monitor with these are the hematocrit, platelet counts, and ACT. Okay, slide number 29. Fibrolytic agents. I think Actabase is the one I've seen the most in passing. So these meds, they stimulate the body's own clot dissolving mechanism. So it tells the body, use your own clotting mechanism to clot the blood. Clot dissolving. So it tells your body to activate its own clot dissolving mechanism, converting plasminogen to plasmin. Plasma is going to flow, which digests the fibrin, the stuff that contributes to causing the clot. Okay? Dissolve fibrin clot secondary to coronary artery occlusion, myocardial infarction, pulmonary emboli, cerebral emboli, and deep vein thrombosis. Streptokinase, that Actabase, is still available but is rarely used. Act during early phases of clot formation, limiting damage to surrounding tissues. Severe adverse effects, increased risk of bleeding, and allergic reactions. So when I said act during early phases of the clot formation, you want to act when the phase is early because it limits the damage to the surrounding tissues. That's what I was trying to say. So with this med, you want to act during the early phase of the clot formation to limit the damage to the surrounding tissues. Okay? Let's see. Slide number 30 is a question. Slide number 31 is a question. And that is it, my class. So that was the last chapter for Module 6. So as you review this video and make your notes from the PowerPoints, or, however you all take your notes, again, come with your questions on Tuesday. Tomorrow at 1 o'clock is the cutoff. If I do not receive them by 1 o'clock, because I want to take time to be able to look at the questions being submitted. If not, we'll just have a powwow session where we just do a Q&A, and we'll just kind of go over whatever you all want to go over for about 45 minutes to an hour on Tuesday. So this is a friendly reminder that we are going to have a Q&A to kind of go over and get your questions answered, okay? Thank you so much, and I look forward to seeing you all on Tuesday. Have a good weekend.